In terms of treatment options, I'm at the end of the line. They've tried chemo, they've tried radiotherapy, surgery, and it's still coming back.
51-year-old Glendon has a type of brain tumour called glioblastoma. He's tried every treatment his local hospital in Lancashire can offer.
This is the most aggressive cancer known to man. You either collapse into a little pile of self-pity, or you carry on fighting. And I will carry on fighting until it kills me.
To access a new type of therapy, Glendon is now under the care of Matt Williams, a leading oncologist at Charing Cross Hospital.
How did Glendon find you?
I don't know. I don't know. I suspect Google.
Matt is one of the few doctors in the country willing to prescribe immunotherapy for brain tumours.
Lots of cancers are able to avoid the immune system, so they kind of hide from it. And what the current generation of immunotherapy does is allows the immune system to get active and then attack the tumours. It's known to work for some tumours. We do not know whether it works for others, and yet it is really expensive.
The NHS does not offer immunotherapy to brain tumour patients because its benefits are unproven, but it can be accessed privately.
So we're going up to the 15th floor, which is the private wing stuck on top of Charing Cross Hospital.
Doors opening.
In most cases, I think private medicine means a nicer room, better coffee. But there has been a change. There are cases where you'll get access to other drugs that aren't available on the NHS. And the number of people who want to access those drugs is definitely going up.
Okay, this is your bed.
Lovely. I really fancy a refreshing Aperol spritz. There must be a little bar around the corner here somewhere, surely.
Glendon is one of Matt's NHS patients. Since his diagnosis a year ago, he's been exploring all treatments, including those only available privately.
This is his Novacure. It sends a current through the brain at a certain frequency that's supposed to catch the cells before they split so they don't set up in other areas of the brain.
Yeah, they don't have Novacure on the NHS. Ballpark figure, I believe, is around about £12,000 a month. But I phoned them up and begged, basically. Got it on compassionate grounds.
Glendon, how much have you spent on trying to cure yourself?
I've only just started.
We've just travelled, really, and saw a
I would
few
say
private.
about 10,000, but I'm now starting to throw big modges at it.
What's the war chest?
£500,000.
But we haven't really got that sat there, have we? Not liquid cash.
Yeah, it's assets.
We'd have to sell, more or less, everything to get hold of it. It will be everything else but the house.
I'm not going to leave my family destitute by a long stretch.
Hey, my name's Neeraj, one of the neurosurgical team. How are you doing, sir? Nice to meet you. We need to get you an MRI scan.
3 months ago, Glendon had surgery to remove the tumour, but it returned and is growing.
I thought we should talk about Mr. Snape. He's now relapsed again. There are no standard treatment options. For a whole bunch of reasons, immunotherapy may well not be effective in glioblastoma by itself. There are good reasons to think that adding immunotherapy to a second course of radiotherapy may be more effective.
And the evidence for?
Poor. The problem is all this immunotherapy is quite new. And so far, the results have been very disappointing.
It's ethically hard. There is no open trial for him. The company won't give him compassionate use. We're looking at self-funding.
So he would have to self-fund. He is well aware of this.
Poor chap.
I had another patient in clinic today explicitly say, I have some money. If there are extra things I can pay for, then I want to know about them. And in that setting, you can't then not tell people about things, because that's clearly the wrong thing to do. When I started in the NHS, I never thought I would have to have conversations with patients and ask them how wealthy they were.
That's the first set of immunology you're going to get, and you'll need 3 doses of that. but it's actually going to be more like 6,000, I think, because he's having a bit less of the drug. So that'll be kind of 24,000 to start with. If that doesn't work, we move on to these two drugs, and that's £31,840. And that's 2 immunology drugs that he might need, and I don't know how many treatments he'll need of that.
You know, you live once, you know, and life is precious. And I do feel like I'm being asset stripped for a cancer which is not my fault. But by doing the immunology, it should, touch wood, buy me more months.
If you go back 10 or 15 years, the NHS essentially provided all the treatment that was available. There is now a gap, particularly in terms of drugs, where the NHS will not pay because funding is flat, the demand is rising, we're all looking at things we can stop doing. And so that gap between what is potentially available and what the NHS will provide is unfortunately going to get bigger.
Katie Urch is the Divisional Director overseeing all cancer services for the Trust.
How does a drug get approval?
Usually a drug has been developed by a company and gone through various clinical trial phases. It is then put forward in this country for NICE approval. NICE approval means that it's been independently assessed as having some degree of benefit.
NICE is the body responsible for deciding which new treatments should be available on the NHS.
We are certainly in a golden era of more and more drugs available, but the amount of added life benefit perhaps is quite minimum. And so the jury is still out on many of them of exactly what benefit we're going to see.
Glendon, who wants to top up his NHS treatment with a self-funded course of immunotherapy, is seeing Matt Williams in his NHS clinic.
This is now post-re-resection.
Glendon has already had 2 surgeries, chemotherapy and radiotherapy at hospitals in Preston and Liverpool.
He's obviously got that cavity, but he's got this new tumour, which might benefit from some of that coming out. I have another treatment which I am intending to give him, which he's come today to see me about, but I think an operation first might be a good idea. My only concern is this is then his 3rd operation.
The main risk I would worry about in him would be a paralysis on the left side.
What I'm looking for at the moment is obviously to stay alive. I've got to kill it. And immunology, as far as I'm aware, is the only chance I have of actually bringing this nightmare to an end.
I think we are in a difficult place.
There's a significant amount of abnormal tumour, and we feel that if we're going to advance the case, then we should try and remove as much of that to get as small a target as possible.
How do you feel about the idea of...
I'm fine because I haven't got really an option.
Is there anything else that you want to ask Miss Peace?
The main thing is, can we do this so that I'm alive? Because I don't want to die. I don't want to do all this and die at the last hurdle. That'd be infuriating for me. Because I've worked so bloody hard to get to this stage.
Sure.
I mean, it really has been. I mean, I've done 10 hours research every day since the day I've been diagnosed. And I will spend whatever it takes. And I know this sounds daft. When I got diagnosed, I thought, there can't be nothing in this day and age. So, yeah, that's where I am. Sorry, rant over.
That's all right. I'll leave you with Dr. Williams, and I'll see you next week. Thank you very much. Okay.
The point of us offering you treatment to keep you alive is so you can enjoy your life. And spending your time till 3 in the morning looking up brain tumour treatments on the internet, that's not much quality of life.
Do I know it?
Yeah.
You've just made my life so much easier.
Okay, but only if you go and spend your time doing something more interesting.
That's what
Traditionally, you used to be able to say to patients, I think you should have treatment X, and you will be having treatment X. And now there's the internet. So it's much easier to see what is the standard treatment for your disease in America, Germany, Norway. And our cancer survival rates are worse than almost everywhere in Europe. And how we deal with that as a profession, how we deal with that as a society is a difficult question.
Welcome, everyone. So let's move on to the first item on the agenda, which is the income report.
In the 5 years from 2010 to 2015, the Trust's income from private work increased by 40%, from £31 to £43 million.
So April, first month of the new year, was actually a pretty good month for us again. So it followed the strong trend of the last 3 or 4 months. I think in terms of highlights, our cancer business continued to show strong growth.
If you can grow more private patient income, that will actually help out with the rest of the National Health business.
Yeah.
Well, there's a lot of enthusiasm for working closer with you and finding the growth.
I think it's a bigger understanding of how private works in the Trust that we need to get those very clear messages going on.
Are there any downsides to doing private work?
I think people think that we make more compromises than we actually do. We know that it doesn't compromise our NHS care, but nonetheless, it's very easy to write a story that says, because there's money in there and because the NHS needs money, surely they must be disadvantaging NHS patients in some way, whereas the truth is that the money does flow back in to NHS patient care.
Then the proposal is to kind of take that income and directly allocate it down to divisional positions.
Is it possible to say what percentage goes back to NHS? And what
All of it. It doesn't go anywhere else.
It could go into private facilities.
It doesn't in our case because we own it. We own all the facilities.
We need all of the things to be flying, and I think we need to just keep doing what we're doing.
We have a financial deficit of 41 million. So if we can make money treating private patients, then it's better that we address our deficit that way than that we have to cut back on NHS services, which is, to be honest, the only other way we can address the deficit.
Okay, great. Oh, keep up the good work.
We've got to get smarter, we've got to get more efficient, and we've got to do the best with the money we've got. I don't think that's a particularly difficult argument. I think it's reasonably well understood. It's just not very popular.
Another 5 big deep breaths there for me. You're doing really well. Starting to feel a little bit woozy.
Glendon's undergoing 3 hours of brain surgery on the NHS to remove as much tumour as possible.
Okay, it's just getting off to sleep now, okay?
Just drifting off to sleep.
The operation carries a risk of paralysis on his left-hand side.
OK to start. Thank you. That's the skull. He's had a previous opening here. The opening, the craniotomy, has been secured with metal screws and plates. Elevate this. Then we have plainly abnormal tissue under here. I suspect this will be part of tumour, this grey, jelly-like substance here. Sometimes they're terribly soft and it would be like resecting creme brulee, but in this case, as you can see, as we grab the tumour, it's very firm. It's like almost a hard lychee or a rock-hard kiwi fruit. This tumour would be about the size of a tangerine. It's almost 5 centimetres across.
When was that? That was, I bet that was about 4 years ago. That's the same time. Oh, that's it. We went to Cambodia and Vietnam. And we were planning on doing lots more travelling. We used to walk quite a bit as well. There's just a picture walking there.
How did you meet?
Through a friend, actually, that I work with. Yeah. So she introduced us. She actually did a reading at the wedding, which was really nice. Glenn hates all these wedding pictures. He says it looks awful on them. To be fair, he's probably ill though, because that was only 6 weeks probably before he had his seizure.
Do you feel like he's changed? Like, how do you feel?
Yeah, it's totally different. He'd gone manic at one point and he was quite aggressive, and I'd have to walk 10 paces behind, that kind of attitude. Sometimes I used to get a bit annoyed at him because I thought, well, you wouldn't be like that beforehand. And even when he's like in surgery now, it's kind of, is he going to come back the same person? And yeah, it's bad enough, like you say, that he's got this prognosis. I might lose him at some point, but I might lose him before I lose him. And to be fair, I've lost some of him already. That is distressing.
On the angle.
Glenn, operation is all finished now. You can start breathing. Deep breaths in and out. That's it. Well done.
We're entering a phase of cancer survivorship where people have been treated and have emerged out the other end. But there will be people like this who are having ongoing treatment, and you're still scanning them, operating on them, and involving health costs. You then become a victim of your own success.
Where's Kate?
Glenn?
Yeah, darling.
Oh, hello.
Oh,
hello. Hi. Hello, sweetie. How are you?
I'm fine. It was just a bog standard one.
Was it? Give me a kiss. Sweetie. Good job on it.
Yeah.
You still move on your left side. That looks good.
Yeah. No deficit at all, by the looks of it. Hello.
When I set out to do the operation, I was aiming for 90% removal.
Brilliant.
I think we did more than that.
Oh, thank you so much. You're a genius. Look at this.
No, I'm not a genius.
You've done brilliantly. You're my hero, because it means that I can start living my life again. And that's what I haven't been able to do for a year.
And if Dr. Williams is happy, that will be the cherry on the cake.
But he's the immunologist, and he says, right, yeah, we've got enough to carry on, crack on with the treatments. I'm happy. I'm the one who's paying all the money for this.
Sure.
Yeah.
Under the Trust's self-pay guidelines, patients topping up their care with drugs not available on the NHS are only charged the wholesale cost and a fee to administer them.
The NHS, quite rightly, will pay for treatments which are evidence-based, but there are some patients who want to go beyond that. And you could say, well, they shouldn't be having non-evidence-based treatments. Well, maybe the evidence is there, but it's not of the best quality.
Thank you.
Fortunately, I'm not sitting the other side of the desk with a potentially life-threatening tumour, and what would one do if it was yourself?
So are you ready for the cup of tea?
Coffee.
Coffee? All right, fine.
Cappuccino.
That'll have to do. Be grateful, say thank you. If he was very quiet, I'd be worried. Last time you pretended I was your sister.
Who are you anyway?
Yeah, don't start that again. I'm glad you didn't play that trick this time. No.
Is there any more water? Your mouth shows the badger's arse.
The work I do here is tightly regulated. I have an annual appraisal, and people keep a fairly close eye on my work. Out side of places like this and other big NHS hospitals, if you just go and see someone privately, there are all manner of snake oil salesmen out there. And I think that worries me. Hello?
Matt is seeing Glendon in the NHS clinic for the first time since his brain surgery.
Well, look at this. Can I give you a hug, man?
I didn't do anything, though.
You put everything in place for me. You took every... I mean, you know what I was down to.
Take a seat before you fall over.
I'm not falling over. I've been walking all day.
OK, all right, then. Well, before you get tired, then. So, we need to talk about what we're going to do next.
Yeah.
We had talked about having another round of radiotherapy.
Yeah.
And we had talked about adding immunotherapy to it in the form of pembrolizumab.
Yeah.
Is that still what you want to do?
Yes.
Fine.
Unless there's another combination which has come out better.
Well, OK. This is the best I can do. We have to make some informed guesses.
If it works, how long do I keep the schedule going?
Don't give you 2 doses of pembrolizumab.
Yeah.
One before and one after.
But I do have to keep carrying on taking for the rest of my life?
No, 2 doses of pembrolizumab.
Right.
Beyond that, I find it very difficult to justify continuing.
I mean, it's not a money thing. It's if it works, I'll carry on doing it.
I know you keep saying that to me.
Have you made a sort of choice about not giving Glendon exactly what he wants? Like, are you trying not to bankrupt him?
Well, of course I'm trying not to bankrupt him. One of the drugs he's interested in is just under £30,000 a dose. I don't think that there is enough data to justify its use.
Immunotherapy can be a bit funny in that because it sort of takes the brakes off your immune system and your immune system kicks off, it can give you lung problems, kidney problems, heart problems, eye problems, skin problems, because essentially it depends which bit it decides.
I heard liver was something.
Yes, and liver. Sign and print your name there.
Is it the role of the doctor to say stop treatment?
We live in a society where people are used to being able to have what they want, and healthcare is not like that. It's difficult because part of our job is to own the uncertainty, to say, here are the options and I will recommend A, I will recommend B, even when in your heart of hearts you're not entirely certain.
In all honesty, I'm not an idiot. Somewhere along the line, it's going to be not treatable.
Yes, but my aim is, where it's appropriate, is to give you treatment to keep you well for as long as possible. All we can do.
That's all I want to hear. I'm a realist.
You're a very optimistic realist.
I'm so pleased.
Nice to see you.
How are you feeling about the prospect of getting the immunotherapy drugs?
It's like going to the bookies, really, basically. You know, you can't turn around and say, oh, yeah, you're a surefire winner here. What I'm trying to do is kick this cancer further down the line. The further I can kick it down the line, the more studies go on, there's more chances of drugs being approved, which are clinically more effective. So that's why you do it.
Hi, is that 15 South Chemo Day unit? Hi, I'm calling from Pharmacy Aseptics, just to say that the immunotherapy for Glendon is ready to be collected.
I didn't want to go to my grave without covering every angle.
Hello, it's 4:15.
You grew up expecting the NHS to always be there for you.
Yeah.
Do you feel that NHS is still there for you?
For everyday stuff, very much so.
So you're staying here? Yeah? Hi, just want to pay for Glendon's treatment.
How does that feel?
It's what needs to be done to get the treatment.
Do you think the hospital, knowing that it's a bit of a gamble, there's no guarantee that
Do you mean
it's
should
gonna
they
work.
offer him this?
Yeah, they've taken a lot of money from
Yeah, but
you.
it's hope for him. And if I went home tomorrow with no treatment or forward plans, I don't think he'd cope. He'd give up.
You're right.
Yeah. Just that there is hope, and you know, it might not work. In fact, it probably won't work. Well, I don't know. I don't like to get too optimistic. But, you know, but if it even gives Glenn something to live for now, it's serving a purpose.
All ready, sir?
Here we go.
Here we go.
Just want a normal life back. I want to live to 70. You know, something like that. I don't want to die at 50.
Looking good. Fusing nicely.
But, you know, you've got to put up with what you're given. And if I can keep it going longer, that's what I'm going to bloody do.
NHS in an impossible situation.
Yes. We're completely screwed. Yeah. The best example of what happens when you have a lot of private medicine is America. It gets very poor outcomes.